And welcome, everyone. I'd like to call our meeting to order.
Okay.
Don's coming into the queue. Please know our mission and vision statements. We'll wait just a couple seconds as Donna walks in to have our consent items organized. Donna. Hi. Donna, we've called the meeting to order. We were just arriving at going over our consent items and it's walking, so we need just a minute so you can be here. Thank you.
I'll move the approval of the agenda and minutes.
Is there a second?
Support.
Thank you. Is there any further discussion on the agenda and minutes? All in favor of approval, please indicate by saying aye.
Aye.
And opposed, same sign. The motion carries. We'll move on to item 4, presentation. And we have this is attachments A and
Yep.
B.
It's Dr. Darren Lubers and Jamie Davis from IBH, which is one of our contract providers. And I have them today to go over, as promised from last meeting, a couple of components today. First, you're going to get a presentation on the in-depth way we looked at residential costs, how we determine outliers and what this means. You'll get a general sense of the average monthly cost and direct cost of every person in our residential system on the IDD side. So there are no solely substance abuse or solely mental health adults in the study. That's the next study. As the board will remember, when I first came here, I declared what I called a residential services emergency. In fact, I did that in the first meeting as an interim, almost the very first thing I said. And this is just understanding it. So to be able to defend that, I said, what are our true costs? What are we paying? How do we determine a rate? How do we determine a level of care? How do we define that? How do we get things authorized in general? Well, after an exhaustive process of close to 7 months and multiple meetings with many of our providers, in fact, we invited the whole provider network for several meetings, determining their cost of care, how we determine it, and working with the IDD services division, we've come together with a new kind of rate level of care description. But the first thing I wanted you to do is before you can determine anything, you have to do what I called a review of foundational sources. And the first thing is, what are we paying? And is there any logic to what we're paying? And how are we determining stuff? So I have Dr. Lubers here and Jamie, who I wanted a third party group to look at our data. I have a long history with IBH. They do a lot of work for us. Darren and I started it here in Ottawa County many years ago. Jamie did an internship here many moons ago. A lot of the employees started here. In fact, they won internship of the year one time at Grand Valley for their program. And then obviously, I've worked with Darren and Dr. Lubers and Jamie for years in different capacities. So they are a nationwide company utilized all over the country for these types of analysis and much more. But Darren, welcome. I don't know if you can hear us. You have to unmute.
Yeah, I can hear you.
Hold on.
Can you hear me?
Just one moment.
Volume on the TV turned on. Oh, that's probably it.
Yeah, now talk, Doc.
Hey, can you hear me?
Not yet. Almost.
Not yet.
Hold on one second. It's connected, right?
Should be connected. Try again.
Hello, hello.
That's not muted, is it? The owl.
The owl.
There's.
No.
How would it know? It would be red. It's
Okay.
red light if
Oh,
it
yeah.
was muted, it's not ready.
Is it connected to the TV?
Yes, I
Is
have
that
the HDMI cord.
But is it like the setting for the TV audio versus your audio? So you go to audio to the left up top.
Let me stop sharing for, oh.
No, go to the left up top. There we go. Yep, you need to go to speaker, Samsung.
Well, they're working on that. Amy, welcome to you also.
Thank you. It's good to be back.
Yes,
I may have met you at one point. I don't know for sure.
About, 10 years ago.
Oh,
So.
okay.
try talking now, Darren.
Hello? No, not yet.
Now, it might be
No.
on Darren's end. We'll get back to you in a moment, Doc. So what Jamie's gonna do is to show you the analysis that we did, looking at the total monthly cost for people in residential services and IDD. You're gonna see a description of in-county, region, out of county. I wanted to see if there was a difference on the average cost for people in different locations in the state and for their total cost of services. So before you can understand this analysis, Jamie has to walk you through how in the heck to read a box plot. So Jamie, go on through it. You can go through this.
Yeah, so we use the box plots to kind of look at our average cost. Because it really just helps us see the distribution. We kind of want to see the spread of the cost of, the different things that are going on. We did look at all the services together for residential, because in some cases, within the residential rates, they may be include like the O2 and PT, but not always. So we wanted to make sure we could get the full cost for the people that are in there. So when we do start to look at it, even case management, things like that are included, just so we can get this full picture. So with the box plots here, in general, what we want to be able to see is the box plot to look very symmetrical. If it's not, it means we've got some skewness, which means there's probably some points or some individuals that we would call just extreme points, or the outlier points, that are kind of shifting our data one way. What you'll see is this big gray box. About 50% of the points will fall within that gray box that we are looking at. And then that gray box also helps us decide what they're called whiskers. So that's the dotted line out to the edge. The gray box actually helps calculate those. And in general, we like to see about 100% of our data fall within there. If it doesn't, that's what we call an extreme point. It's 1.5 times the gray box on either side of that. So we'll explain it more if you have questions. It gets easier as you see more of them.
Yeah, so the dots to the right or left of the whiskers are outliers, one way or another. And you'll see how that plays out. Does that make sense? Yeah, it takes a while though.
Yeah.
But the one-on-ones were not included,
They were.
correct? They were
Right.
not in.
They
They
were.
were.
They
It was
were-
only in the regionals, the regions evaluation of residential costs, which they excluded both total costs, which we didn't do, or one-to-one costs. We included everything. That's a different report from last meeting,
Oh,
from the Lakeshore Regional entity that I said missed half the data. So this is our own independent evaluation, not
oh.
related to the attachment A from last meeting where we had from the region.
Perfect.
Yeah, so you can ignore that report while we're going.
And then the last thing is so inside the gray box, there's a black line. That's the median. Half of the people are gonna be below that, half of them are gonna be in front of it. The black square is the mean. What we wanna see if the data is normally distributed, that black box and that black line, they're right next to each other. If they're not, we've got some influential points that are either pulling our mean up really high or really low. The reason we like the median is because those extreme points don't tend to pull anything. I always think of it as houses. So if most of the houses in the area, let's just say, cost about $500,000, we've got 1 or 2 really expensive homes. We don't want to say that the average cost of the house is, $1.5 million, $2 million, just because you got a couple $5 million homes, right? We want to say that the average cost of the house are about $500,000. So that's why we tend to look at the median, but the mean does tell us something. So we can go ahead and scroll down. Perfect. So yeah, on the next page here, the first thing, kind of like Dr. Brashear said, is we looked at all of the DD residential consumers, their average monthly cost for all of the services together. So this is just everybody at one time. We had 196 individuals that we looked at. We also looked at this from October 1st of 2023 through April 30th of 2025. So we can get a good reflection of what these average costs are. So if there were some months that were really high or really low, we're trying to kind of smooth that out here. So what you can kind of see here is in general, we have a pretty normally distributed box plot, except for those outliers on the side. There's 12 of those. So there were 12 individuals where their average monthly cost was more than 15,800 a month. So $15,000 a month.
Right, and so when we say all costs, it's everything the residential providers doing, anything we're doing in addition to residential services, supports coordination, anything. So is there a difference in total cost? So if you just look at residential rates alone, it doesn't tell you the whole story. You have to look at the total cost of people in residential in different settings to get to a true average. Some residential providers provide stuff for us. Some don't, in addition to the residential services. So it was important for us to look at that, and every dot to the right of that whisker is a person. It's not just like it's a real individual. And you can see that one of them is costing us, this is monthly, close to $31,000 a month. For this one individual who's getting a huge array of services in our county, not out of county. If you're a residential provider, this isn't somebody on the other side of the state we hear about that are more expensive. It's someone in our county. And then we did an evaluation of each outlier, which we'll talk about later. Does that make sense so far? Tara, can you talk now or are you done? I used to.
Well, I mean, can you hear me?
I can always call him.
Yeah, I don't know why it's.
Yeah.
And then you can.
We'll just
Yeah.
call you Doc.
Michael, quick question.
Mhm.
This, you said includes all of the consumers here in Ottawa County. What about consumers from other counties who are receiving services here in Ottawa,
Not in our stuff. We have some COFR agreements, those things, but they're not.
but they're not included?
All right. So then we said, all right, that's everybody. Is there a difference in different ways we slice the data? And I think that Jamie
You want to
wants,
start ringing.
it's okay. Yeah. Yeah, I don't know why it's not working. It's usually Luber's fault, by the way.
It's tough when you got only one person.
He can hear us.
Yeah, they can hear it online. Yeah.
Hello.
Hey, can you hear me?
Yeah,
You're gonna
Okay,
have to talk really loud.
I'm talking really loud.
No, you're gonna have to.
Oh, I'm gonna have to, okay.
so Darren, I'm gonna let Jamie go through a couple of slides, then I'll have you make some comments. Is that okay?
Sure is.
Okay.
Perfect. So this next one, what we wanted to look at is kind of like Dr. Brashears alluded to. We wanted to look at the cost of the individuals, total cost of care for those that reside within county. So that's their residential home was within Ottawa County. Or out of county means they're in Kent County, Muskegon, different places like that. It was kind of a thought process that there was a potential that those that are out of county might cost a little bit more than those that are in county. And that's sort of what our analysis showed here. So you can kind of see now when we compare the box plots, this kind of makes it a little bit easier, maybe a little bit more fun. The black lines, you can kind of see right there for out of county, is a little bit more to the right than in county, which means 50% of those people are gonna cost a lot more. Out of county than in county. There's also a lot more variation, right? The whiskers are a lot longer. So there's a lot more variation out of county in the cost than we see within county. You do have outliers kind of on both sides, but we can also see when we look at this that an outlier out of county is gonna cost you just over 19,000 a month. In county, they kind of become that outlier extreme point over 13,000. So there's about $5,000 difference on what we're seeing with the cost there, just with some of that variability and kind of the expense.
And of course, with the only exception being in the in-county, the two dots far to the right. And you should know they're not in traditional specialized residential settings. They're using CLS around the clock different code altogether, and it's far more costly. So they were choosing to be in a different setting, using a different code that we use. It's not the traditional specialized residential setting. And we've done an analysis of who they are and why they're costing that much, which we're investigating to address. But that kind of shows you, and we even broke it down further, in county versus out of county. We do much better with our providers in county in providing a total package of service because the coordination of care is done between us and them. Or in out of county, some of it has to be done between us going out or contracting with somebody else to do supports coordination or PT or OT. And so you want to try to keep people in a local setting as much as you can in county to help stabilize cost. And that's one of the reasons why you need to make sure your rates are good, where you can't keep specialized residential programs in your community, and it can almost double in cost if you don't. So it's because we're able to coordinate care as what CMHs were intended to do in county.
Do you want questions right away?
Sure, go ahead. You can answer, yeah.
Okay, and this is kind of related to the whole in and out of county, and your
Right.
point, we want our Ottawa County people here as much as we possibly can have.
Right.
Has it been factored into this that maybe those may be hard to place individuals who we sought a placement for in Ottawa County, were not able to find one, and their care needs are that much greater? Was that taken into consideration?
Yeah. In terms of how we place somebody, those are major variables, like where is the most appropriate setting? In Ottawa County, it's hard to develop new placements, even though you'll hear today, we have one provider extending 2 homes, creating 2 homes. That's good for us. But our first attempt, and Leah will tell you this, is that we're always trying to do things here in the county. Are there some unique level of care needs that people meet outside of the county? Well, yeah, but that's just because we don't have a lot of providers. And I mean, if we had more, the providers we do have, like Harbor House, they take high physical need folks better than anybody in the state. And Benjamin Soap with the total package around folks, we just don't have enough of them. And so we're forced to use out of county. And you'll see in a moment, we even looked at out of region, like, is it still within the region? So that was the first layer of consideration.
Another follow-up
Yeah.
question on that, is it, what is the total number of consumers in county and out of county? Is that listed?
Yeah, in county is 131. Oh, that's an order, 131, and there's 65 out of county.
And is it possible that one of the reasons why we have 65 individuals receiving services outside of the county is because the parents live on the extreme eastern edge of the county and they don't have enough providers there, so they're moving across into Kent County to get their services
I
nearby?
mean, I don't know if you want to talk about that, but it's mainly what's available.
Yeah, I would say it's
Yeah.
nothing really to do with where the parents live, or the guardians, like a lot of the guardians, parents still are living here in Ottawa. And it's really just, there's nothing else available at that time.
But Tom, to your point, if I may extend it, the logic, if we had a region that was functioning in unison with exact same level of care criteria, rates, and commitments to providers, what a wonderful idea that we'd have a regional benefit that families could maximize in multiple counties instead of I want my Ottawa County, but we don't usually hear I want to go out of county.
We
fact,
still have
that's rare.
people moving here to Ottawa from different states.
Yeah.
And then needing residential for their son or daughter.
Okay, anything else on that one? So you get a sense of where we are. And you look at the table is really just the table representation of the graph above it. So if you don't like looking at box plots, just read them.
Then you can know what the numbers are, you don't have to
Right.
guess.
Right.
So,
Then what we did, and I'm gonna talk about this a little bit in my brief presentation, we created 3 different levels of care. One of the things that I discovered when I came back is that we had a historic system of trying to develop rates for providers. And we had kind of like a general idea on what we would call it. But through the years and through the state dropping tools like the supports intensity scale and other scales to help determine someone's need, we've done the best we could without it. So we had to kind of create our own model based on what we reviewed financially and what people were getting. And there came up 3 terms, which I'm gonna go over in my presentation: family license, which is a licensed AFC home that someone can live in, that people usually live in. It's not a general AFC. It's a specialized res. Traditional specialized residential, which what I'm saying is kind of like your general, your basic specialized residential that have a high variety of needs. And then clinical wraparound, which is a percentage of folks that need a lot of additional care, which I'm gonna go through, and you'll see a slide on that in a moment. But I said, all right, let's put people in categories and where they would fall, and then look at the total cost. And then Leah did that primarily by looking at our list. It's not perfect yet. We still have to work with providers to say, do we have them in the right category? But what we found is there's a bigger range, and you can go through what that says, but my suspicion was correct. There's a whole group of people, a large group. They're getting more than you would normally think in a residential. Residential care is not just personal care and getting them to the community. A lot of these programs are running like programs, and which I'll get into in a moment, but we wanted to stratify them and say, all right, let's put them into categories. And does the level of care we have them in match how much we pay and the rate we're paying? So you can kind of go through that, Jamie, what that's kind of telling you.
Right, so I think too, with what he's saying is the box plot on the top, which is the clinical wraparound, is like the most intensive. And so the thought would be that that would cost the most, right? Most intensive program and things like that. And so we kind of were hoping, we originally did this to see this like stair step approach, right? The higher the clinical services, the more expensive that's going to be. You do see that a little bit. I will say from my perspective, what jumped out is the median for traditional specialized residential and clinical. It's almost the exact same.
Right.
They're, pretty much right in line there. So about 50% of the individuals in those services are gonna cost above 9,000, 50% below. The big thing I would say though is on that clinical wraparound service, that it is very much skewed to the right, so positively skewed, because we have those kind of extreme points, really pulling that mean to the right. So when you take a peek at that, you can kind of see there. Plus, the other thing is on that big gray box, the median is almost all the way to the left, which basically what we end up seeing is that top 50% of these people, there's so much variability. 50% of the people in that, level of care is going to range somewhere between 9,000 and I think we have $17,000 a month.
Right.
So there's just a lot of variability there. And I think, that's where we really dug in to understand maybe why. Is it the person? Is it the setting? What's going on there? Because you just don't always expect to see it. And that's what we want to just kind of
Yeah,
understand.
and what I took away from that. So we have a whole range of providers that are providing a high level of care at dramatically different rates and supports coming to them. So I looked at that and went, makes sense. We got some work to do. Because that top group, there's a lot of variability in terms of how much we're paying for services and total cost, but the clients have very similar clinical plus presentations. And so that's not good. We want that to be to the right, but a lot smaller in terms of the ranges. So before I could even get into what are we paying rates and what we're doing with providers, I needed to know what we're actually paying and how we would stratify it. Because if not, you're just guessing on what the rate could be. So the huge range of costs on that top one shows me a lot of work with a lot of challenging people, with a lot of variables that are not consistent. And we got to make them consistent. And we've been working on that the last month. Would you agree? If you disagree, don't disagree. No, is that kind of how you see it, or am I kind of?
No, that's very accurate. Like,
See, Leah knows every client by name, disposition, and what's going on. So without having us writing all this down, if she was abducted by aliens, we'd be in real trouble. So we had to start taking it there and putting it here.
Yeah.
What is the process by which the level of care is determined?
My presentation next will show you that.
Okay. Before we get to that, though,
Mhm.
you have 58 consumers in that clinical wraparound box, or 5 of them outliers, but 53 of them in that box. They're not all getting the same services.
Correct.
So you have a range of services. This consumer may get a service that cost $500.
That's right.
This consumer receives a different level of service that's far more expensive to deliver,
Mhm.
that may cost twice that.
And it's based on the need.
Yeah.
Yeah. And
So
a
it's
lot of
not the
their,
same service. This placement is $500, and that same service over here, we're paying twice as much for. It's because the individuals in that clinical wraparound group have a wide variety of needed services.
Right. yeah, the biggest driver is one-to-one cost. Is the biggest driver. And further to the right, the more someone needs one-to-one staffing around the clock.
Mhm.
And just at $20 an hour for 24 hours, you're already at $480 a day without even doing anything else. Haven't even eaten yet. Right? So that's a lot of the variability in that range is the level of individual staffing.
Without any, of course, identifiable or personal information, can you give example clinical wraparound? Like, is there something that would help us know?
Yeah, you're gonna get a description of it right after she's done.
Okay.
Like I have a
Okay.
paragraph on it that outlines them all.
We're almost done.
Yeah, we're getting. I guess my point is before we could even define what they were, we needed to see how the costs were distributed.
It's easier to see.
Yeah. Yeah, let's go to the,
Yeah, so the last piece, the one last thing we wanted to do here is because what we wanted to look at is we had already seen, right, out of county looked a little bit more expensive than in county, also level of care. Clinical wraparound a little bit more expensive than traditional. Wanted to make sure that when we were looking at this, that the level of care wasn't, in out of county or in county, right? Were most of the people that were out of county in clinical wraparound? And is that why it was more expensive? So we ended up breaking it out this way, and I will tell you that was not the case. And so what we saw here is when you kind of look at these boxes, it's broken down by level of care and then the distribution of costs in and out of county. So when we look at the clinical wraparound, what we can see is out of county is that top box. I definitely can't read it from here, but I know
Yeah.
that that's what it is much wider. There's a ton of variability on that. There are 18 consumers out of county in clinical wraparound, and there are 40 in county in clinical wraparound. The thing that jumps out the most here is in county, it's really tight.
Right.
Like we see, right, most of the costs, about 50% of the individuals are somewhere, this morning, somewhere between $7,500 and like $9,000. Out of county, it is somewhere between 12 and 17. So they're just more expensive. There's a lot more variability there. And so we can really say that that's not really what's maybe driving up the out of county cost is the level of care. Traditional specialized is that middle box, and those look very similar, maybe a little bit more variability out of county, not a ton. We have number of consumers in that level of care are a lot closer. It's 43 and 56 for out of county and in county. Got 2 outliers on that extreme side. We did just update this, which isn't in your packet on this analysis because we had found that there was a billing error. And so they forgot to bill you guys. And so we were like, yeah, you're kind of actually skewing the data a little bit. We're going to kick you out. So we've got it, a little tighter now at this point. But in general, here is what we're seeing. And then the family license home kind of looks like we would expect as well.
Mhm.
So.
Yeah, and it's tough that, when I looked at this analysis, I said, my providers in Ottawa County, they're pretty tight, what we've been giving them consistently. There's a lot more variability out of it. So from a rate standpoint, you seem to do better if you're out of county, which is a problem for all the stuff we're saying. And so remember last month you improved the rate increase for Harbor House Emergency. They're to the left of that box. serving some of the highest need people. So we weren't even, they were like on the left side of not the right side of things. And so we were correcting something, and you'll see that as we go through this. And I promise I'll get to the definitions of each of those in a moment. But I really wanted you to see how in-depth we're looking at this from a cost perspective, in county, out of county, total cost, right? Before we even said, what are we paying people? We needed to understand this. This took a lot longer than one would think going through. We went through Avatar to Auto to, but luckily IBH knows where all our data is and Avatar. And they can get to it. So we didn't just kind of go, yeah, I think we're paying a lot. I wanted to know like where we were down to the penny. Darren, do you have any comments that you'd like to make on this analysis from your perspective, Dr. Lubers?
Yeah, certainly. And can you hear me okay?
Yeah.
Okay, great. Well, one of the things I've always appreciated about working with Dr. Bashir is he and I have similar backgrounds in terms of, clinical work. And so one of the aspects of this where I believe we're both hoping to take this is that it's critical to examine costs, but it's also critically important to look at clinical excellence or the treatment delivery system. And so, one of the things that I think this tells us is that it would be great to be able to have a deeper understanding of the clinical delivery system to determine if it's possible to develop like an evidence-based framework for this, where we're looking at not only cost, but we're making sure that people are having like the clinical or the treatment components where they would receive optimal care. And so what's so wonderful about this is that you can study outliers, but you can look at, like Dr. Bashir's already alluded to, is it that we're just paying more in out of county, or do individuals have like a differential set of requirements? And if that's the case, that's the case. But making sure that we're good stewards of the costing model, but making absolutely positive that our clinical model is in alignment with that, center of excellence type logic. So I think like this is like a critical step to be able to look at, all of the treatment services delivered and the efficacy of those services and the costing models all together to be able to, potentially strengthen our delivery system. So when I think of where Dr. Brashears and I go way back is when we were at CEI and I was working on evidence-based practices. And so one of the things that I think both love to develop is like optimal delivery systems for whatever population that one is serving. So when I see this, like what I also see is evidence-based practice fidelity scales. I also see, being able to get a really good handle on, what are the absolute needs of the consumers, particularly, in this outlier group, and see if we can, strengthen all of those harmoniously. And so I love this work. In fact, quick funny story about Jamie. Way back when she was an intern at Ottawa, I had said to her, so how would you like to learn all about factor analysis? And so one of the things that we did that was absolutely a wonderful project is looking at, the actual supports intensity scale and examining like, are consumers getting, the optimal services for what their assessed needs are. So that kind of brings it back to why this kind of work is so important, because at times you find people are getting more, sometimes less, sometimes exactly what they need, but until you measure it, you don't know. So you're able to make certain in a system of care like ours that those alignments are happening. In other words, good steward of the costing models, but making sure that we have optimal clinical evidence in terms of our delivery system. So yeah, that's what I think of when I look at this. I love this kind of work. It's really important. It's going to help move us forward. And you have a great team there.
Thank you, Dr. Lubers. We'll be calling on you in a moment. I think there was one more you wanted to show them with the blue dots
Can
everywhere.
I ask a question before we get to that?
Yeah, that's the one you're looking at.
Dr. Lovers, I think what you have done is a critical piece of evidence for us to gather. But I see something missing. We've looked at average costs in different categories, different buckets. The difference is the people we're measuring are different.
Mhm.
So if you were to take me as a DD consumer and send me to provider A with a PCP and a plan of service, and it happened to be here in Ottawa County, and then take me and send me to provider B in Ottawa County and measure what the cost is there, that would be statistically important.
Right.
And then send me over to out of region,
Mhm.
over to Kent County, to provider C, and see what the identical consumer with the identical plan of service and presumably the identical number and frequency and scope of services being delivered. We haven't even talked about the quality of those services.
Sure.
But then the next question is, does provider A cost a little more than provider C, but is provider A doing a better job for the consumer? So the quality of the services needs to factor in here somewhere for us to really make decisions on what's a better setting.
Yeah, no doubt.
Mhm.
Yeah, I mean, it's a great comment. And that kind of goes back to that center of excellence logic that I was bringing up. I think one of the critical things is that you're able to determine, like with an objective rating, the actual services that are being delivered on a scale to make sure that you're getting exactly the services that you think you're receiving or in terms of what you're paying for. Those are all done in terms of like EBP type logic with what are called an organizational indices, where you're really able to look at the critical delivery systems that they're providing and then have them from an outside entity, or that entity in this case could be Ottawa, could be like a LEA helping to look in and making sure that those services are similar in nature. Does that make sense? Because you make a great point.
The other point is what we're finding is these are programs, not just personal care and CLS providers doing care. We're finding distinct types of programs doing a wide variety of supports with different things. So your point is well taken, having quality expectations, but the first thing is to validate that in a residential setting, they're doing way more than personal care and CLS. That a lot of them are asked to be behavioral psychologists, nurses, OT specialists.
Right.
There's no validation of that cost. And so when we were coming up with these ideas, we were thinking of that concept. Benjamin Hope is a program. It's not a personal care CLS factory. There's a whole thing there, right? To get to quality. If it was just on cost savings, I'd do what every other CMH does. I say, oh, the new rate is the average, it's the median cost for each level, and it's now $108 a day. Good luck. Well, there's a reason why people are outliers, legitimate reasons,
Mhm.
not illegitimate. I mean, I don't think we're off by that much. Like, oh my God, we're paying somebody $32,000 a month. We didn't know. There's reasons that person's on 2-on-1 staffing and all kinds of things. So we kind of figure it like that. And this helps us get to those questions on why someone's an outlier, what's unique about them, what does it tell us about those types of services, and what we need to say they cost versus how much money have we spending, how much do we got, and doing it that way. If that was the case, we take every median line you say, and that's the new standard kind of cost we're willing to spend on somebody in that range.
And
Which
I love that point of view, and I actually think that you might be onto something in that there might be another level of care that's actually in this data. Meaning that there are a subgroup of consumers that just have, to your point, very high one-on-one and two-on-one type staffing needs. And if that's the case, I think there might need to be advocacy to the state in terms of these individuals are just, expensive and getting the services that they need. That's very possible.
Okay. I have 4 slides, but Jamie, did you want to show anything else? Yeah. It's the next one with all the blue dots. Big scatter diagram. This shows you everybody, right?
Yeah, so this is just the last piece that we looked at. So instead of just saying in county and out of county, we looked at those within the region.
Mhm.
And then outside of the region, right? So the LRE is basically, Kent, Muskegon, so the LRE region minus Ottawa, and then outside, I don't know where you're considered outside of, but
Everywhere.
outside of that. So there were 16 outside of the region, 49 in the region, and then 131 inside of Ottawa County. And so the one difference too with this is the blue dots are all individuals. This way you can actually see them on there. It makes it a little bit easier as well. Especially with that top one, you can see it looks a little bit different. I think this is the only time that the mean is below the median, which means
Right.
we've got some individuals that are really on the lower side of things, pulling that mean down. And then I think that the blue dots really help you kind of see where those are and can kind of understand why that mean is being pulled the other way.
So when you look at other evaluations and they only look at the average or the mean, they're missing 3/4 of the story. Why is the average the average? So last month you saw a study by the region that gave you averages or the mean without one-to-one cost, without total cost of service, just residential rates for 2 codes only, and only the mean. That'd be like showing you just a small black dot in every one of these things. You have no idea what that really is. So while I agreed with some of the statements of the regional entities study, the methodology is incomplete. And we've been sharing this data with them, saying if you're gonna come up with a regional idea, then you have to look at total cost, out of county, in region, and include one-to-one cost. And that's where you got confused because you read last, one-to-one cost and other stuff. You can tell that it doesn't tell you anything. And it's not to be critical, but to say, good job reaching right direction. But we have spent 7 months trying to figure out, what are we looking at here? And it does take that long when you're doing it thoroughly. So I wanted the blue dots are to me, that's the people. I know who the far right dots are. I know who, Leah's told me who they are now. So we know who all these people are. And they're real individuals with unique costing needs. And this gives us a sense of how we're looking at it. So Darren, stay on the line. I'm gonna go through one other thing real quick, and then I'd like your input on it.
Okay, sounds good.
Yeah, so I just put 4 slides together and some other things around our system. Okay, it's gonna come up in a second. And I will be 10 minutes. As usual times. Yep. I wanted them to have all the time. So you can hit slideshow there. So basically, I'm gonna cover 4 slides of what we've been doing with our system, but you need to understand that we had to do the foundational source review of all of the finances to do this. So the first thing is,
It's showing up on this.
it's okay, if you just click on the number 2, and then that way I'll advance it, I can do it this way. So I'm gonna look at the level of care description, our authorization process, level of care determination, and rate determination.
Need to share it. Sorry about this.
All right, we're getting better.
You see it?
I can see it.
Yep.
Yeah, so those are the 4 areas I'm gonna briefly cover, so go to the next slide. So it's in the other order, okay? So the first thing we did is going from
Sorry.
lease intents.
I'm just trying to, I'm so sorry. This is messing up everything over here. 1 second.
You don't have this in your packet. I put this together right before the meeting based on 5 different documents I couldn't get to Joe. So, we'll get there in a second.
So sorry. For just a second. Unplugging.
I can see something. I saw Dr. Lubitsch. Yeah, okay, I see the document. I just minimize Lubers. Yeah, just, you can't see where the cursor is, yeah.
I can see it on my
There it is, there you go. Oh, just slow down, you'll get it. Yeah, there you go. Go right there.
I need to share. That's what I'm trying to do. Can you do this again?
Mhm. Okay. Got it?
I think so.
All right, good. So this is from least intensive to most intensive. Knowing that we just proved to you that even in some of the categories like traditional, specialized, residential, there's a wide range. So these are general statements. In general, we have a family home level of care. These are licensed AFCs, specialized residential programs, and not general AFCs, where most of the time they have a live-in model. And they don't require a wake staff, even though the reality is the people in these settings may have needs and observation needs, they can be maintained without somebody being awake. Okay, this is the least common of what we have. And a level of care that's shrinking by the day. These are the people that have like done it for years and they're finally retiring and there's no replacing them. And if you remember on the costing, their costs were all relatively uniform, not a lot of outliers at all, okay? Traditional specialized residential, the ability to care for individuals during all hours of the day, meaning awake staff, and usually shift staffed. Individuals in this level of care have the need for high level of monitoring for at-risk behaviors, at-risk multiple medical interventions and appointments, and a need for significant amounts of hands-on intervention and may require significant environmental modifications. The staffing ratio is usually at least 2 staff per 6 residents or 1 to 3 at a minimum. So that sounds pretty restrictive. There's a lot going on there. It requires residential care. It requires assistance and prompting in many different levels. It requires a lot of coordination there. So it's not like middle of the road, oh, they're easy. There's a wide variety, and this is the bulk of the providers normally would be defined. What popped up is this clinical wraparound. Because before, everybody thought clinical wraparound was really part of traditional specialized residential, that level of care. I've split it out because I'm saying there's even more than that description that's not considered in most rates and not dealt with in terms of what we're providing. And this is the difference between traditional specialized residential and clinical wraparound requires the complete coordination between the guardian, the client, us, and the provider to help determine this. It's not like I have a checklist, even though I have a checklist, but for a different reason, that says, oh, you're in this, okay? So the ability to care for individuals who have care needs that exceeds the level of care which can be provided in the traditional setting. These individuals may require full support and multiple activities of daily living. Full support means 100% assistance. Not prompting, not assisting, full support. Like everybody that lives at Harbor House that needs help with feeding, full support, right? ADLs, activity daily living, 1-to-1 and sometimes 2-to-1 supervision. We have some individuals that require 2 staff with them at all times, 24 hours a day, because they need it for behavioral issues, elopement and AWOL issues, harm to self, to other issues, and full support. These people used to be in Mount Pleasant many years ago. They're now in the community, which is great, but they cost $31,000 a month. That is not in our rates that we get from the region or the state. This is a group that we have to really look at and determine, are we being reimbursed by our funders to deal with this level of care? My answer is no, we're not, and I'll tell you why in a moment. But they require 211, a restrictive behavior management plan. Every single one we've identified in this level of care has a behavioral plan with restrictions in it. Like preventing them from leaving or locking cabinets or all kinds of stuff. Now, that's not to say that doesn't happen in the other level of care, but these are, when you put them all together, a different type of program that's needed. Significant psychiatric instability may require very high intensities of clinical support at a given time to ensure the health and safety of the individual. So what I did was kind of like family live-in model, which is shrinking, doesn't need 24-hour observation. A bulk of everybody else with a wide variety of needs, some of them complex. And then this other group, which is extremely important. There's tons of different supports around them at all times, or they would not be able to be maintained in the community. And so those are the general descriptions of that. Did that help? Did that help you?
Question, when you say the family group is diminishing, are you talking about just the number of homes or the number of placements?
Both.
That are needed?
Both. The number of placements that we have is inadequate to meet the need.
Right.
The number of homes at that level, if I have this right, are shrinking. People are like, I'm no longer willing to do this. This used to be a much more prominent model 20 years ago.
Mhm.
There was a lot of folks that, and living in and taking, and they're watching everybody. This is shrinking. But guess what? The needs are going up too of the
A
client.
lot of times the folks in the family homes have been there for 30 years, right?
Right.
So their needs have actually grown to
Sure.
be more in that traditional specialized
All
level.
right, so they're,
But since the provider has been caring that for them for 30 years,
right,
they know,
so it's based on need and not by default. Because we're running out of placements.
Well, it's both. I wish we said yeah,
yeah.
I wish we had a system to say everybody's in the right level of care.
Okay.
We don't.
Mhm. Okay.
And sometimes because of availability of providers and what they can do, and we have some folks that probably need a higher level of care in our system that are in a family home,
Okay.
because they know the family so well.
That's helpful.
But if I had it my way, they'd be somewhere else, once it starts not working.
I understand. Thank you.
So are they still receiving then a lower level of funding to support that,
Yeah.
even though the needs are going up?
Okay.
So we only have 5 consumers in county who are in that category of family license.
No, you're looking at that 5 out of county that are in that category. We have 34 in county.
Okay, so out of county here means,
I think in the box it's Swimmers. I think it's the other box.
oh, okay.
Yeah.
Okay,
We have a lot of.
that helps.
Yeah.
I'm like,
Like-
I think I know them all.
No.
Probably even.
Yeah. Yeah. Not to mention the tons of people in general AFCs that need any of these 3.
Like
We
they're
haven't
not
talked
in
about
any of,
this.
those individuals aren't in any of these reports.
No, the general AFC folks. We'll get to that another time, because that's a crisis.
So the 196.
It's just
Just us.
who is receiving funding basically from
Yeah.
medical.
All right, so if we go to, so that's just a general description, which we'll be talking about for months and months and months, so you'll get sick of hearing it. At one point. So let's go to the authorization process slide, click on the link. If that doesn't work, I can wing it. You'll have to hit control, there you go, because it.
I open over here, I'll drag it over. Hold on.
There we go. All right. And you can X out the comments. There we go. All right. So this is a general authorization process. So if somebody's already in our system, the supports quarter and case manager will say, hey, we think they need residential care. Now, you'll see we have a checklist to determine that, a form to complete, a way to determine that. So they have to fill out our new specialized residential request form. I'm not gonna go over every form we have them. There's gonna be a manual we have in there, you'll be able to see them at any time and show, okay? So they click out, they complete the form and it goes to Service Review Clinical Care Committee. Each of our major programs, DD adult and MI adult, and then, you know, the kids, if they need it, there's a different process, has to bring this and has to go through a clinical review of the clinical team to say, are there other supports we could be bringing into the natural setting so a residential setting is not needed? So even though they're like, hey, we think they may need residential, we have a clinical team, Leah attends there and Amanda Fry attends as well, to say, we think they need it. We look to see if everything else has been tried clinically. There's also a utilization management group that I have that's not in this group that does the same thing, okay? I put that in place. If it's denied, the request, well, you know, the consumer and their guardian has rights. So if they say we want residential, we say no, that's actually a notice of adverse benefit determination. If we just deny a request, so there's appeal rights for every single person that's in our system that says, I want my loved one or myself, I'd like to go in residential, and we say no. And that's through the region and then ultimately through administrative law judges. Most of the time, when folks seek residential and they meet the criteria, we're looking. But I just want to let you know, it can be denied. And it can be denied because we're like, we haven't tried anything to keep them in the natural setting. Now, if they're living with 92-year-old parents, and the 92-year-old saying, I can't do it anymore, well, that weighs heavily on our determination of have we tried everything, okay? And our committee that we have, Utilization Management Committee, where most of us on this table sitting there, Anna's always reminding her, did we try it? We say yes, and we go, okay, we'll go through there. So we're looking at that piece. Then Leah completes our residential assessment and level of care determination. We have a decision tree that was co-developed with IBH, Jamie and Dr. Lubers, and some of us to say, all right, based on answering these questions, yes or no, where do we think they would land just at first glance at our 3 levels of care? And so like, and then I'll show you that in a moment. And then obviously we figure that out, and then we start looking for placement opportunities. And that's when work with the providers begin. And that's not the end of the story in terms of determination, it's the beginning. Because our providers then take a look at what we have and say, we think they need this amount of staffing, not this. And I'll show you how we deal with that. So this is give you an overview of like, hey, I think they need residential. They fill out this form. It goes to a clinical group. There's a UN group that looks at it. The UN group does not deny the placement. It just asks questions. Utilization management should not be the place where you deny somebody's clinical level of care. And that's where most managed care companies go wrong. Okay. And so we do not do that at Ottawa CMH. If there's a clinical need and the placement is needed, we initiate that level of care because I shall provide appropriate services based on their need, not may based on finances. So assures certain things, but cannot prevent it. Other system says the committee said, no, I'd be appealing that left and right. They don't have a right to do that. So go to the next slide. Does that make sense? I said 10 minutes, that 4 minutes left. So if you go to the level of care determination slide, Leah, this will look familiar. I will describe it. We developed, it's going to load because it's there you go. So there's like a decision tree. Okay. And this will be given for feedback from our provider group to look at to see if we have it right based on the logic. So does the consumer require 24-hour monitoring residential care? Yes, keep going. I mean, do they need 24-hour monitoring? Second question is, do they have to be awake? That's the first definitive thing between the family model and the rest of them. If the answer is staff doesn't have to be awake, then we could say, what type of other supports can we do, including a family specialized residential where you don't need awake staff? So that way. So the decision tree starts walking you through some key areas. Does the consumer require one-to-one staffing for health and safety? If yes, you're going, all right, you're already in the clinical wraparound level of care to begin with. So then what else is needed? And so you keep going down this matrix, if you can scroll down, and then it has like different hours, like while awake, 16 hours. And if you're from Benjamin's Hope, this will look exactly like what we've talked about. How many hours in a day does someone need it? Does the consumer require one-to-one with the community? Do you know at Harbor House Ministries, if they were to take all of the residents out for a community on the same time, they'd have to have 30 staff come in immediately. Because 32, excuse me, I left 2 out. Every single one of them needs one-on-one assistance for mobility and community inclusion. So when the state puts in a home and community-based standard for having 2 outings a week, no one is figuring out that they need 32 hours times the amount of people, times the amount of hours of each of those things to accomplish that. Now, you could stagger it, who goes out when, and use existing staff, but that's not in the rate. It's in our rate. And I'll show you how we got to it. So this keeps going down, and it gets to Dr. Lubers and Jamie. You'll see we took stuff per your feedback and ours from, and for the audience, from the SIS to high behavioral medical, and say, all right, what is the rationale for the supervision? And so do they need, no need, monitoring, dangerous, disabling, intensive action? Almost looks like an ANSA, if you know that tool. 0 is like no need for it. 1 is like you better monitor that thing, like fire setting, right? Well, if it's happened once in their history, but it hasn't happened in like a year or 2 or 2 years, we still give it a point.
Because then they start a fire again.
Right. So this isn't so many points equals something. It means justifying why we're saying they need to be in the right level of care, clinical wraparound or family or traditional, right? And so there's one for behavioral issues. And if you keep going down, personal care, full support means full support. Yeah, that little box drives me nuts. There you go. We have stuff like, do they have physical and medical things that require like suctioning, feeding? This looks like any of these assessments, but we're using to say, what ballpark are we? Not, and the score is 11, you get $50. What clinical need ballpark are we in? So it brings you all the way down to this thing, and then we end up having average number of medical appointments per week, all these other questions. We get this data, then Leah goes, based on this and the need for one-to-one and all these checks, we're already in a clinical wraparound type of level of care. Who are providers that can provide that? Which is a trick question because they all can with resources, okay? But the point is, we start looking there. We're not gonna look at a mom and pop family thing for someone with this need, right? So this helps us get to the determination of, all right, who do we want to engage as a provider and then set the rate? Does that make sense? Not the other way around. Now the rate is this. It's to begin the process, not to end the process. And if you're a provider, you know that's a fundamental difference than what you've experienced. It's usually we've determined the rate and say, can you live with it? And you go, I don't know, what are the needs of the client? And we go, all of this, and you're like, are you mad? Right? So like that's what we've been facing. So you go to the last, does that make sense on how we're doing that? So that is done all internally. From the request to a decision tree to a determination on a general ballpark of a level. And then I'll show you an example of kind of how we're doing rate setting. Yep, thank you. I'm over my time. I have 2 more minutes. This is the drill down committee. So, okay. So in terms of rate determination, this is not a done process. You can make that a little bit bigger if you can somehow. If you can't, don't worry. If you're in the audience from Benjamin's Hope, this should look very familiar to you, because based on our general rate calculator that we built at Ottawa, we've asked providers to try to come up with a way to make it unique for their provider, for their setting, and ensure that we're looking at the cost. And so what I want to show you is not to explain every thing, but to tell you that a lot of this is based on the actual cost of staffing, like the actual people, their supervisors and supports around them, based on the provider's actual costs that we verify. So it isn't like, oh, they're just making it up. We make them prove it. So what you do is like the direct care, this is all based on an individual, right? The direct care hours per day this person needs at different rates, average wage, unemployment insurance. Scroll down, please. If you can, there you go. Works per day, cost of judgment, overtime. We go through this thing. What was their average of overtime that year? What was their turnover rate? What does training cost? These are all kind of cost adjustments that are not usually made in traditional rate determination by other folks. They just say we pay for personal care and CLS. Well, all of this stuff is actually the cost to do those things that are usually not accounted in by a CMH, but the providers have to deal with. Okay, so and then you get to like in this particular person, the total costs were per year $143,000. That's about average that's about where we're at when you look at some of these needs on the other document that you saw, that the monthly cost can be high as 20,000, 30,000 per month. That's far more than that. If you go to the right, it's okay. It's like having you ask AI assistants and then scroll up a little bit. A lot of the stuff in the left column are generated on the table to the right. I don't expect you to grasp it. I just want you to understand how in-depth we're doing this, okay? So we're actually looking at, by the way, Benjamin's helped me today to change a couple of things on this, okay? So like when you look at where it says first shift, second shift, third shift, the amount of hours is 3, right? That divided by the number served, that actually means like you take, does this person for the first shift, this would indicate that they would need 8 hours of somebody individually being with them, that they're only serving one person, that person. So you can see like in second shift, some of the needs go down theoretically with this person, and they're able to help more than one person because they don't require a one-to-one the whole time. They can do that. And then the third shift where someone's usually asleep, there's usually, for a 6-bed home, at least 1-to-3 ratio in there. So they're saying, look, this one staff member can watch at least 3 people overnight if they had to. So the reason why for me showing that is that we actually, if you go above that, you can't see it, know what their actual rate of pay is. We know what the agreed upon staffing level is going to be and its cost. The biggest disagreement we're going to have between a CMH and a provider and maybe the guardian is how much one-to-one care they need. And we have a new one-to-one guideline that we've developed that we're reviewing with everybody to help determine that. The true cost of care is really related to how much support somebody needs individually to accomplish everything in the person-centered plan. Really, so how do you operationalize all that? So we even put the supervisor in there, right, as a factor. These homes have to be supervised. And then we add some administrative rate to deal with the amount of administrative burden, about 10% of the cost, right? So you'll start seeing in this next several months and all through the fiscal year, when we're making rate adjustments, if it's to an individual, you'll be able to see the calculations we used. You'll be able to know how we got there. You'll be able to know how it's equitable, the approach for every single person and where we have them. So you're allowing for individual differences, Tom, in a rate based in a consistent model determining that fully involves the guardian, us, and the provider and the client. No more, here's what your rate is this year, live within it. It's not working. We have already had several homes close in Kent County. We're 25 to 30% less our rates than the other providers in our region. I just need to be able to demonstrate a competency in determining all this with our partners so that you as a board don't go, oh, we're just increasing rates because, Dr. Brashears wants to give increases to his residential buddies, which I'm accused of. Boy, I wish that was the case. I would have been doing a lot less work the last 8 months on this or more. But this gives you a sense of how we're getting there. And I know there's a lot of questions and what each thing means, believe me, but we'll have a whole orientation. So every setting we go to, we're gonna have a version of this rate calculator that fits that client and that setting and say, help us fill it in. We're thinking they're gonna be in this level of care based on our decision tree. We know how much we've been paying you. Has it been adequate? The answer sometimes is yes. We have one provider that I went through this with, said, gee, I can do a 15% decrease because I don't need the same amount of one-to-one anymore. That was one of our outliers. She's like, I better start getting that moved the other way. I said, unless the client needs it.
Right.
Right? And this provider said to me, you know what? I've had to use some of the money from this client to offset the cost somewhere else in my system. And that's not right either. I should just get them there and these people to what the real cost is, and I won't have to do that. There's no incentive for any of our providers to actually tell us they've made any progress with any of our people, because then they could lose money. When the cost of care doesn't change much unless you're talking about one-to-ones. And so we have to like get the system to get that way. It's gonna take a while. It's a 2-year process. Does that make, like, you get a general sense of the sophistication we're doing? We're not just kind of, that was my point to showing you this, is that there was a comment in public comment at the board that we don't have a level of care system, that we have no way of determining that. Oh, not anymore. You know, having IBH, but having our providers and Leah's knowledge and everybody's knowledge within CMA has made this possible, and we're gonna get there, so we'll be able to defend this. And by the way, we need to do this for every service we do. That's managed care. That's why we looked at total cost. Why is supports coordination costing more here versus there? In a moment, you're gonna see a contract that's a DCO contract for CCBHC that if we provided the service directly, would be 3 times more expensive. So we need to do it for CCBHC to have a DCO, but you can see why we're doing it that way. So decisions will have a logic model connected to it that I think that the finance committee, PQI committee, and the board will be able to see over time, over and over and over again. So questions on that?
Yeah. Well, I was gonna say, Michael, you're talking here about direct care costs for specific services that we are required to provide.
Mhm.
The package for the provider is more encompassing than that.
Mhm.
They have capital costs for their facilities, they have operating costs for their facilities, for the residential service component and food services that they provide that are outside of the services we provide. And would it be helpful just everybody may not be familiar with how that works, but
Yeah.
if we have a consumer who is placed at one of the facilities, one of the specialized residential facilities here in Ottawa County, where does the money come from to provide those other services?
So there's a way to break it down. Medicaid can only be used for personal care and CLS services outlined in the Medicaid provider manual. It cannot be used for food, room, boarding, facility cost, administrative costs over a certain percentage, any quality enhancement to your program outside of who's delivering personal care and CLS. That's primarily funded by 2 sources, maybe 3, see if I got it right. The first is through Social Security Disability, that AFC providers can collect it to help offset the cost of room and board and facility. It's never enough, being one that's managed one, to cover it. Even if you have 6 people in a home and you get 6 of these things, you're capped how much Social Security you can take from them. And it's not enough anymore to cover inflation and the actual costs for facilities, room and board, food. You might get a bridge card for that from the client you can use. It's very complicated. So what's the third source? Fundraising. Those are the 3 areas. I think I got it right. Medicaid, Social Security Disability, which we're not part of. They have to do that with the provider, and fundraising. Some of our providers have to fundraise 30% of their costs. Oh, yes, and we have used millage to offset the non-Medicaid costs of the things that you were just talking about. Right? And if the Medicaid rates would have actually covered the cost of the Medicaid services, we might not have, big M, had to use millage to keep them going up.
Yeah.
But that's a big might. Thank God for millage, because it's offsetting those other costs outside of Medicaid services. But I've said we have to align this with the Medicaid rates, because none of this, scroll down. Look at just at Benjamin's Hope. You don't mind me doing this. These are what's not in the rate. The executive director, the COO, the CFO, the finance manager, the director of administration, director of residential, director of behavioral health. By the way, these are all bits and pieces of position. She doesn't have like full-time people for all this, okay? Just so you know that, right? Okay, a nurse. No, we don't have one nurse in our rate, okay? Clinical support, training, fiscal support, facilities director, assistant facilities director, membership, bits and pieces. These are the things that are not in the rate. You go by Benjamin's Hope, all of the farm animals, not in the rate. All of the people that support them, not in the rate. People think it's in the rate. People say to me, oh, you Benjamin's Hope, you're paying for llamas or whatever it is. I'm like, alpacas, excuse me, I always say llamas. I corrected this, I'm like, if it was a llama, maybe. No, but no, like they have a pastor, we don't pay for that. Millage hasn't been paying for that. It's been paying for facility cost, food, those things. And so each one of those rate sheets, we're gonna list in that setting, what is it not covering? So the public knows, we're aware that this rate doesn't cover this. There's a long list, you could have put a lot more in there. Right? But that's the funding sources. A millage had to be used to keep them afloat. But it wasn't used to pay for the Medicaid services provided. It kept the provider open that provided Medicaid services. But if you're not careful, millage starts to supplant it over time because you need more and more of it to cover all the costs if the Medicaid rates stay too low. I don't think we were even paying the cost of the direct care workers to work the shifts we needed them to work with our Medicaid rate. That's the problem. That's why we needed a rate calculator that's based in reality. But it's expensive. When you do, I mean, it's more expensive than what we're spending now with the Medicaid.
What bucket does training come out of? The training manager.
Yeah, so the training, there's a small portion and some rates that are calculated for it, but not enough to cover that position or actual total cost of training.
Right. Obviously, one of the big issues is turnover
Mhm.
of staff. And are there things that can be done to try to lower that turnover number by incentivizing or anything like that?
Yeah. And we were using some of our millage to do that, some
Yeah.
targeted things to do that.
Yeah.
But we actually calculate the turnover rate as part of the rate calculation here. We do, nobody else does. So the reality is, how do you incentivize it? Well, to me, it's like, if you pay a livable wage, jobs come to
Part of
you.
it, yeah.
Mhm.
Yeah.
If you don't, it doesn't matter what you incentivize.
Because for everyone that turns over, you gotta retrain them.
Yeah, and
They gotta staff.
And I forget the total number of trainings, there's like 20 something I forget the total, I don't know if you know.
Yeah.
Like, there's so many trainings, it's ridiculous.
Over 100.
Yeah, and they gotta keep doing that several times a year.
Right.
So, but, yeah,
It's important to look at.
yeah,
Any other comments from the board or any other, I guess? I just want to say, Amy, we have Dr. Bashir's, Dr. Lubers over there. This is great work.
Yeah.
It's
Yeah.
hard work, but it's great work.
The data really help. It really helps us make decisions and kind of look at the rationales of why we're doing this.
So thank you for
Yeah.
all the work and time that you guys have put into this, and we look forward to seeing how this impacts the people who we support. All right, then, any old business? None that I'm aware of. The only thing I'm gonna quick throw in here, if any of you who are here would like to make public comment, we can throw an extra time in now. I know that we really appreciate people coming and supporting the work that this committee is doing, so. But there will be one at the end. Okay, thank you. Then we'll move on to new business. the July 25 amended, renewed, and ending service contracts.
Mhm. I'm up.
You
With
and
Bill as my backup. See, Bill, if I got this right. And eventually I'll be able to move this over to Bill in this committee. But remember, when we were doing this at the full board, I thought it'd be best for me to kind of do it. But over time, we can kind of trade off on these ones. That sounds good. So what we have is two amendment contracts. One is for Samaritas, and we have Joel from Substance Use Disability Services here to help with this. And this is really, we started under a CCBHC. We were required to reach out and get a DCO, like a subcontractor with us as part of the CCBHC program. You must have them. We had to bring them online. And this is a substance use provider that's gonna do that for us. And we had to adjust the rate up to basically match the level of expenses that they're going to incur from doing this service for us. We get it reimbursed from the state. And I even threw in, which Bill warned me against, but I did it anyways, how much it would cost if we were to do it versus having the DCO to do it. And those are their numbers have a lot of variables that could be changed to make it less expensive or not. But we have to do this. So all we're asking to do is amend this current contract with Samaritas to include these substance use disorder services to increase the rate that matches their expenditures that we will get back in reimbursement from the state. So it's not a true increase in expenditures. It's a little bit different than other contracts where you're doing that, because part of CCBHC, they look at your expenditures and they give you that extra payment to actually cover it. So the current rate we had for similar services before they were DCO was too low to match the expenditures they need to do it now, which is the same problem we just had with the residential providers. So in this case, though, we get extra additional revenue to cover the increase. I think they got that right. Okay, and going through with my stuff. Joe, you want to add anything? Did I get it right?
So with CCBHC, we have to provide certain services, and one of those services is called intensive outpatient services, for IOP. And it's basically 3 hours a day, about 3 days a week. So it's, on average, it's between 9 and 18 hours of clinical services within a week. It lasts about 6 weeks. So it's to really help stabilize people. Our services that we provide in-house, we just don't have a client base that we can provide that service effectively to the population. So that's one of the reasons we're pursuing the DCO agreement, is we're fulfilling that obligation to provide that level of care, which we already do with contracts, but they're not that special DCO agreement. And so we're pulling in Samaritas to have that DCO agreement to be able to provide that level of care within our CCBHC system. And like Dr. Brashear said, that revenue that will generate with the daily payments will make up for that rate increase.
Okay. So I don't know if you vote on these individually or should I go to the next one? and you-
Yeah, just go right in.
Okay, so the next one is to increase our capacity in our specialized residential program through Benjamin's Hope, who has two houses that, so two? Yeah, two, that are opening, that are open and opening. And so I bring this to you, because anytime we increase the capacity, I want to make sure you know. And so then inevitably people say, Michael, are you going to fill it to capacity? Right? So the finance committee knows that we're in the process of examining and having, based on what you've just seen here, who would be eligible. We already have people we know of, identified, put in the right level of care. And you will see increases in the residential budget going up based on people going into these much needed placements. And we're gonna use that, we've used the rate calculator, we've determined the need, we're kind of in the final stages of that. But it would be disingenuous of me to say, oh yeah, we're just increasing capacity, we're not gonna use it. We're gonna use it, and we're gonna stagger it over time. And we're gonna look at the rate based on the level of care that we're telling you. So when I have things like that, if I absolutely knew, like, okay, maybe in another meeting, when we see an increase in our residential budget, when we're looking at kind of budgeted increases in any line item, I'll have to explain to you how we got there. But it's not like each residential person is gonna get approved via a contract here. So this increases the capacity to our system. It's in our community. And so
What it does right now, it allows for Benjamin's Hope to kind of move current individuals within the homes to make the compatibility of the homes better.
to move them to the new ones,
So it's not like new people, but like just being able to shift around a little bit.
And then you'll be filling in beyond that as needed.
As needed.
Yeah.
Okay.
The, the one fallacious, assumption that could be made is, we are generating customers to go into these available places. I think a better approach would be to say, what is our pent up demand? What is our backlog of need for services? How many people are waiting for an opening for a proper placement?
Oh, yeah,
And is this just a step in the right direction, but that still does not satisfy all the demand?
that's correct. The way I frame it, and it is how many people are holding on in their natural setting for a place? Because as you know, we can't have a Medicaid waiting list.
Yeah, right.
So we've
But we have
communicated,
waiting. We have people
we've
waiting.
communicated to
People in a
families.
pool,
Yeah.
swimming in a pool.
Yeah, we've communicated to families, can you keep holding on? Was it 3 board meetings ago? We had a 90-year-old person, right?
Yeah.
Okay, right? And so how many do I think we need? There's at least 50 people.
Yeah.
And if we increased our residential budget by 50 people, right? So we're doing it as planfully as we can, but the whole population's getting older. The need is increasing. And some CMHs, the residential budget's already 60% of their total budget. So CMHs over time are becoming specialized residential and whatever else we can provide. And we have to be very careful that, we do this. But you are correct, the need is far greater than the capacity that we have now. Hence why there's so many out of county placements, blue dots way to the right over there. Because we just didn't have it in our community or anywhere.
But we do place off of like the urgency.
Yeah.
So, I mean, the needs are brought to my desk on a daily basis, right? But it's that urgency, like the 90-year-old parent. They're at the top, right? So if there's an appropriate placement coming up, like they're gonna be slated for that placement. And for that particular family from a couple of months ago, for him to stay in county was super important. And they wanted to hold out for income placement, right? So I mean, that's always a choice too of, do you want us to look out of county? Because at this, right today, we don't have anything to meet your loved one's need, but we can look out of county and see what we can find. And they didn't want to go that route. So that's kind of the deciding point too, is how long can the family keep holding on to? And we just hope and pray that no crises happen.
What is your time estimate, if you're looking at other potential, spots? What's your time estimate between like when you think that might be filled?
Starting next month,
All 12 spots?
not all 12, but starting, we're starting aggressively to look at it.
I would say the homes would, and it doesn't, I mean, Benjamin's Hope can look to other counties too. I mean, they contract with Allegan and and the state of Michigan, right? So I mean, the word gets out so fast when a provider is expanding. It's like wildfire, literally.
Yep.
So all of those counties, I'm sure, are contacting Benjamin's Hope saying, we want in on these beds too. So I would say Benjamin's Hope, the new homes would be filled by the end of the year. But they're probably not all gonna be Ottawa folks.
Okay.
But Does
Yeah,
that
and
answer your?
yeah, and to some extent, we also don't want to lose the opportunity to have
Right,
in-county spots.
right, yes, it's
Yeah.
It's a balance, right?
balance.
Good discussion. Right now, we're looking for a motion that, remember how we divided the contracts now into new and this is for the amended, renewed, et cetera. Is there a motion?
I'll make a motion that we approve the amended contracts for similar tests and Benjamin's Home.
Support.
Been moved and supported. Is there any further discussion? All in favor, please indicate by saying aye,
Aye.
and opposed, same sign, please. That motion carries. And now we'll do the same thing with the new service
Yeah.
contracts, which is tax 50.
And these are, as you notice, our new contracts are, except for the renewals will be huge the next couple of months, but the new contracts, if you notice, are, right? What these are, two interesting. One is to offer, training CEUs through one of our grants so that our nurses can, get some much needed CEUs. And it's a $3,000 thing from the System of Care Grant, lump sum payment to this organization to provide CEUs for our staff and community members for nursing. The second one is just a change in ownership of one of our existing residential providers. We've done due diligence, we've checked the new owners, but technically it's a new contract, even though none of the expenses are changing or anything. It's a new contract. And Lee, I don't know if you want to talk about that one at all, like who these people are.
So this would be like the family home level of care, this provider. They work really well with our MI population, which we have a pretty great need to expand housing opportunities for those individuals, so the current provider is retiring. They actually found someone to take over the business, so there are no current openings at that house, so it literally is just a name change. But when you retire, you have to relicense too. You have to go through Laura to relicense, so they get a new license number, so that's why we have to bring it to you guys too. So,
Yeah, it's a new contract, so.
I was actually hoping it was new.
no, unfortunately,
No.
it's not new, just new
No.
provider, new ownership.
Those are the two.
That's it?
Yeah.
Is there a motion?
I'll move we approve the two new contracts presented.
Support.
Been moved and supported. Any further discussion? All in favor, please indicate by saying aye.
Aye.
And opposed, same sign. That motion carries. And now we'll move on to our June financial statement. We've got Amy here.
Okay, so we have, year-to-date financial statement of activities through June 30th. I think one of the first things, to point out, as you know, throughout this year, we have had a weighted target, a percentage target, and this is the first time we've been pretty close to that weighted target, so I think that's a positive. As we're getting into our third or final quarter of the fiscal year, some of those numbers are coming together. It's kind of hard to see where, revenues are still under our year-to-date budget. We did receive, I think, 4.8 million in payments right after the report was run, and then another, 2.5 of CCBHC, so those revenues have come in closer. It's all kind of a timing with our payments for the month, but again, expenditures, year to date, we are still underspent for payroll, so we have vacancy savings that kind of offsets. Our general client care is still a bit over our budget, so remaining close there, and our current trajectory is within the $1.3 million of for the year. So kind of steadied out and coming a little closer together. We are we've received notification, I think this was mentioned at the last board meeting, that we had an incentive payment for CCBHC that could be around $300,000. We're still in the process of, resetting our PPS rates for CCBHC, which would be paid retroactively. And so that will have an impact on balancing. Hopefully within this last quarter, we'll bring our, revenues and expenses to a close, at a closer number than our, cost settlement for fiscal year 24. But things seem to be positive and normalizing, and, you know, for the first time, that target number was pretty close. You know, we've been, quite overspent, so hopefully it'll stay within our, like, those weighted averages are giving us a better sense closer to that. So that's for the mental health fund. Millage fund is right on target as well, kind of steady. We've done all of our one-time payments, and as the year wraps up, we're kind of just wrapping up the, monthly expenditures that are budgeted, and, revenues are already receipted for those. Well, I don't know if there are any questions or comments or.
Since this was printed, when the report, the mental health and the SUD fund goes to the full board, the numbers that you indicated will be changed?
No, I wouldn't change this from now to Friday.
Okay.
And this is also, I'm not sure, there is a, the special funds, which mental health is a special fund, is part of the county's quarterly report, so it also will align with their quarterly numbers that the county board of commissioners will see in their Q3 report, so, that's why I always put the date prepared, so it kind of gives a sense, but I always try to say, well, you know, 2 days later, we got we got a bunch of payments, or, you know, we had to pay payroll, and so then it kind of knocks it down, but it does put it in perspective in general where we're trending.
Okay.
If that answers your question.
An encouraging report. Given where we were.
Yeah, right, and, you know, there are still some, we have, you know, we really wanna, we're working hard to bring in as many, CCBHC enrollees. We, have identified some enrollees in the transition into PCE that, you know, we may generate some other service activity, retroactively, like services that we found that weren't identified with our prior system, so we're trying to bill for those too. So, you know, hopefully all those things will be, come together for year end and keep us in a, stabilized position. I still think we will have a deficit, but it, you know, hopefully wouldn't be as large as it was for 24.
Question for you, Amy.
Mhm.
On the millage, income
Mhm.
for property taxes. We have an annual budget based on what we anticipate the millage, revenue will be for the year.
Mhm.
The year-to-date budget, is that simply a percentage based on the number of months?
Yes.
So that's
Yes.
3/4 of the year,
Mhm.
straight line. That doesn't the actual represents the money that's actually come in. We've done the
Yes.
billing cycles for property taxes. They're gonna be big chunks of it that come in.
Mhm.
So I guess the question would be, what do you think the year end will be? Obviously, we're over budget right now based on that 9-month average.
Yes, and so what happens for the property taxes, the treasurer's office does all of those calculations at the beginning of the fiscal year. And so, and none of the collections really start until January, but most people will pay their taxes by April, so those revenues are generally in by April, you know, with a few outliers and, you know, maybe late payments or ongoing payment plans or, you know, like other taxable payments that are made after that fact I think that projection, obviously it gives us we've already receded more than was projected, which
Yeah.
is a positive, and going forward, I wouldn't say it would probably increase much more than that. I think, I was just looking at that. I think last month we receded like 280,000, so that's May, that's still kind of close to April. But even if it were, 100 to 150,000 in a month, we might even accrue another 250,000 from now until year end. But, I don't.
The other question I had was on CCVHC. Right now, year-to-date actual revenues, 3,354,000. Do we know what our expenses are year-to-date? Do we know whether we are profitable or have a loss in the CCVHC project?
CCBHC expenses are under our revenues, when we're calculated. It's one of those things where, yeah, I can try to figure out a way to report that out.
I'm assuming, for example, we had expenses during the month of June for CCVHC that we have not received the reimbursement for yet.
Correct.
So there's a lag there. So even with that lag, we've gotten 3,000,003 in, but we don't know what time period that covered. Did it cover through March? Did it cover through April? Did it cover through May?
That actually, we haven't received payment until this past week since April. This was through March.
Ooh.
So, some of that is because there was a delay waiting to see if we get our PPS rate changed sooner.
Yeah.
Part of it is what happens is you have to move the money from the base Medicaid dollars to CCBHC, so you kind of pay yourself with a portion. And we got paid ahead for some of those expenses, so that's why the numbers are low. We had to put it back. We had to deduct it. And yeah, I'm trying to think what else. We have quarterly reconciliations, so we've only reconciled for the first 2 quarters, so we'll be reporting through quarter 3 in the 1st of August, so we'll reconcile for quarter 3, and then there'll be a resettlement of those payments, so I think more of those revenues will come in. Yeah, it is hard to see, we are behind, it's a $5 million behind. Some of that is service activity is lower than projected. Some of that is, that they're traditional specialty services and not classified as CCBHC, so it's kind of, they fall in both categories and where they get paid out.
I mean, this is literally the problem, the
Yeah.
complexity
It's only
of trying to answer a basic question. Are expenditures greater than revenue? That's what you said. Our answer was no, but let me tell you the 19 variables associated to why that might change any second. But it makes it really difficult, and we do this like all the time, and are sitting in rooms going, how do we explain a moving target when the people that are defining the targets change their mind? We don't even know the amount of revenue we're gonna get for the extra payment yet. We're still debating it with it. How much extra money we're gonna get per service? Which, is it this much? Is it this much? And we're keeping our expenditures at pace with that. But that's why when Amy's answering it, she's like, well, it's Medicaid base and you pay yourself. To answer your question, we are currently under expenditures for CCBHC with a moving target. And as the revenue goes up, we allocate more expenditures towards it, believe it or not. So like the encounters go up, more expenditures have to be. So that's the problem with that whole model. Does it generate money? Sure. But you know, I did a community forum on CCBHC. I've read the manual 3 times. I'm still trying to figure out what in the heck, how to understand it. And there are work groups that meet multiple times a week that half the people in this room are in that are still trying to figure out what the heck we're doing with it. But we are seeing increases in traditional Medicaid. Out of the 100 and something million that was sent out from the state, we're getting a portion of that. It's around 2.4 million. Is it in the reports? Kinda. In some areas it's in, some areas it's not. It looks like our portion in Ottawa for Medicaid will be 1.7 going backwards and then another 700,000 going forward of additional Medicaid revenue we got out from the push out. It's not fully articulated in all the financials yet. Next month, you'll be able to see it clearly. Even the region has a hard time reporting it. But that money did make it here. Now, CCBHC will still figure out how much the extra payment rate's gonna truly be. And we're still negotiating that with the state, with the region, and everyone else. As soon as we know, we can populate it and get to a better answer, but this is best guess.
The dilemma as a board member,
Mhm.
I'm trying to come up with a way to explain this in a different scenario. We run a hotel and we have a restaurant and we have a swimming pool and health club that we allow private memberships in, and we also have a golf course. Now, is the restaurant making money? Is it worth spending the money for the health club because it's bringing in more customers to the hotel? Is it worth it? How do you make that decision?
Okay, so it's worse than what you think. So it's not better. It's, you have to provide all of the services in this estate, regardless of the level of funding for each one. So yeah, they want a restaurant, they're eligible for the restaurant, they get it. If they want a massage, and we do have one person that gets massages from Medicaid, they get it. And so it's worse where you can't even do a cost benefit analysis on the service type you're offering based on funding source. Right? So CCBHC, we could get at the end of the demonstration, decide, okay, we're not gonna continue. That's about $8 million, $9 million hit to us, right? But to bolster your point, it's, you get the full menu if you're eligible for it, regardless if we have any money. So Amy calls it landing the plane on the right runway with all the funding sources. We don't want to hit a mountain on the way, right? So the way we're managing it is we only are funding urgent things we must do contractually. And within CCBHC, find the best system we have to limit expenditures so we're not at risk, even though the county has a position on risk. We're not at risk and we maximize the extra payment to make it at least cover the expenditures to do it. And how you determine that, they keep changing the rules all throughout. I think we're on version 2.5 of the CCBHC handbook.
Yeah, another version.
Yeah, right, which says, oh, by the way, we're changing the whole payment model.
A huge change.
So you take the various Medicaid funding sources and you go, they all have obligations to them in the waiver programs, and are our expenditures always aligned correctly to the right bucket? No. That's the art to it. And that's what we have to get better at. But I don't know, if Donna, I've tried to explain a million times CCBHC, I still, you know the initials, but if you know more than
I
that.
told you. 2 weeks later, I'm like.
LMNOP, right? But I'm telling you, we got the state looking at it with us, we got the region looking at it. My thing is we're bringing in new Medicaid revenue, we're controlling the cost the best we can and what we have control over. And we're making sure our provider network stays open. That's kind of the big movements with all of this data. Because if I get into the specifics, I might make a decision like, well, this isn't, I don't want to do this anymore. Oh, wait, we have to do it. Like DCOs, we have to do it to be part of CCBHC. We have to expand out beyond ourselves. You don't have to have a million of them, but you gotta have some. And so we did, not tons. So I don't know if that helps, but you know, you said that example, I'm like, oh, I wish it was cost benefit of which, I'm like, we had to offer it all.
And is it right to say that if we were to shut the CCBHC program down tomorrow, we would have to shift the services that we are providing under that umbrella back under the Medicaid umbrella, and our Medicaid deficit would increase?
Yes, and we'd have to cut about $7 million in expenditures here. That's people. So impact analysis is the name of the game. As Dr. Lubers is still on the line, thank God he's saying, he's taught me contingency theories, like always thinking of different contingencies for various things, and he's actually modeled them out with me before, and we will have to do that. Like, we don't know what's gonna happen with procurement, with who's gonna manage the system, all of these things. And so we have to build multiple contingencies. And I'm looking at it from a health and safety standpoint and prioritizing which issue I focus on first. And it's been residential, CCBHC, and getting a general sense of how we get our money from the region.
Amy, on the, graphs that are,
Mhm.
is there anything that you would like to point out to us?
I'm sorry, I was just looking at the revenues for CCBHC and the general ledger. Now,
Is any of the, if is there anything that you might want to? If not, it's fine, but just-
yeah, I think, you know, it represents our activity pretty, well. Year-to-date revenues, you can kind of see where, Medicaid is on track between the capitated and Medicaid, which is sometimes we've been under, receipted for those, dollars. I don't know, I guess, nothing stands out as unusual or different from normal trends with all those service reports.
I like the other one with the contracted and direct. I love that chart.
Mm,
Remember the one like, what is it? I think you have it on your screen. Yeah,
Yeah.
I love that one. That gives you a sense of what we directly operate and what's contracted out per service type. So yellow is contracted out, I believe, is that right? Yeah,
Yep.
and blue, and so there's so whole service divisions that are 100% contracted out. And then there are service types. Now, this isn't every single service we do. These are general categories. So like home base for family services, we directly operate it. It's like a ACT level of care for families, which we have a vacant supervisor position coming up that we have to fill under contract. So, because that's a vital thing. So that'll be a vacancy I'll be asking to get filled. ACT crisis. Now, if this chart was over at Network 180, you'd see a lot more yellow. A lot less blue. Besides CCBHC services, you have to do 51% of them. But, you
Well,
know,
all of them, I think, continue to give us good information, and even though we don't have a lot of discussion around them, thank you for generating them each time.
mhm.
So is there a motion to approve the financial statement, which is attachment E, and bring to the full board?
So,
Support.
Moved and supported. Any further discussion? All in favor, please indicate by saying aye,
I,
and opposed, same sign. That motion carries. And as we're wrapping things up, any general information, comments, and meetings attended by our board members? Hearing none, is there any public comment today?
I do have one. I'll be quick. I want to thank you for this collaboration. Where Leah is correct, we're serving 6 counties throughout the state of Michigan. and we're so grateful for that. I also want to say, are there any questions that you have for me? I appreciate the discussion about dental. Anything fun? You know, when we think about what rates mean, it translates to our staff. Our staff start at $18 an hour, which annualizes to a little over $37,000 a year, which is barely above poverty level for the work that they're doing. So we're grateful for the recognition that our rates need to be sufficient to continue to employ our staff. And I'd love to talk more if you ever want to. Thank you. I have none except to know.
Thank you both for being here.
Dr. Loopers, any comments? As we conclude?
No, really happy to see that proportion of direct services. I think that's wonderful, and it's something to continue to solidify. But great job with the data analytic presentation. It looked great, guys.
Thanks, Don.
You. And did you know that people in our county who have your last name are called lubbers? Did you know that?
I do know that, but do you want to hear the funny story? So my dad, now whether this is true or completely one of my dad's, one of his made up things, that's not now, but he used to say that you always have to say the name Rubers because Lovers was from the cattle rustling side of the family.
Amen.
You know, like German pronunciation of our last name. So there you go. Like I said, might not be any truth to it whatsoever.
Well, thank you for being here and thank you for sharing that. Oh, and I think then we're ready to adjourn our meeting. Thank you everyone for your participation.